Tulipoanza miaka mitano sasa kushirikiana na CDC. Lvct Health started as a research project by the Liverpool School of Tropical Medicine, and it was a research project looking at the feasibility of implementing voluntary testing and counseling in Kenya for HIV, and it started in 3 research study sites where they trained counselors to offer HIV testing and counseling. When the research project ended, the project kind of continued as a community-based organization, at that time called Liverpool VCT Care, and lately we've been called Liverpool VCT Care and Treatment, and recently we rebranded to Lvct Health. So the organization started with very few people as a research project, grew onto a non-governmental organization registered in 2001, and has continued to grow since then into now a national level organization. For the last 13 years, Lvct Health has been the leader in HIV testing and counseling and has remained focused in this area of work. So staying focused on the mission of what the organization intended to achieve. I think another factor for success has been the adaptability to change, because in our NGO sector, things do change depending on various factors, some internal and some external. And the organization has been very adaptive to change, very receptive to change, and quick to change when there's necessity to do so. The work we do requires not just knowledge and skills, but it also requires passion and a true belief in what you're doing, in that it transforms people's lives. And we have a very dedicated staff to the cause and the mission that Lvct Health aims to achieve. Because we do both services and research and policy advocacy, we've also been able to pilot small models of service delivery and then scale those up at national level. Much the same as we did with starting VCT and then VCT becoming a national program. So that's how we operate. We pilot model of service delivery and programming, and then we scale it up through government has the ability for massive scale up than any NGO does. So that's why we work very much within the national priorities and very closely with the relevant agencies like NASCOP to scale up services and programs.
The UNGANA project began with a lot of anxiety. First of all, we had to look for credible organizations which could fit into our program, and that was not easy. We did the advertisement, the shortlisting, and eventually we came up with organizations whom we thought were credible and whose capacity then needed to be built in various areas. That was not an easy process, but eventually we were able to get the organizations who were willing to work with us, and we thought we could partner with. We were looking for local organizations, either community-based organizations or non-government organizations which are local but could benefit from our experience and also from our mentorship. And we wanted organizations which were therefore existing and not just imagined, and at the same time they were to be organizations which could do the work, really could do the work, and at the same time were willing to partner with us.
This was a capacity building grant, so we were not looking for perfect organizations. We were looking for potential. We were looking for organizations that had the potential to grow and that were in areas where we felt there was a gap, so they would be able to fill in a gap in terms of increasing the coverage of service provision in the country, and also in terms of increasing uptake to services. And when we say services, we're looking for partners who had programs in 4 different categories. In the 4 categories, we had abstinence and Be Faithful programs. We had programs that were condoms and other prevention programs. We had those that were offering HIV testing and counseling, and we had those that were offering blood safety programs.
HSS stands for Health System Strengthening. It's actually an international term that is meant to describe how we build health systems to achieve certain results in healthcare. And using the WHO has defined them into 6. It has 6 pillars of health system strengthening that go from the point of human resources for health, strengthening quality service delivery, ICT, infrastructure, and other things. So those are the components that we as an organization put together and kind of adopted and based it on local organizations to start what is known as Organizational System Strengthening, or OSS. We believe that as LVCT we have grown. We have grown from a small organization, which was just a research project, to what we are now, which is a large local organization, which is able to compete at international level with other international organizations to get resources to do programs. We use the lessons that we have learned and how we have grown to build other organizations. So hence the Organizational System Strengthening, where we'll address organizational issues like finances, their management, their structures, the leadership and governance, and then the technical component. So it combines the 3 in what is known as the Timisha model. So the funding is from PEPFAR through CDC Kenya, and we have worked closely with CDC to build these organizations.
Some of our sub-partners have been implementing HIV testing and counseling. HIV testing and counseling is really just going out there for people, providing a service for people who do not know their HIV status. So we have static sites, and these sites are open on a daily basis where people would come and walk in and get those services which are available at the site. We also do HIV testing and counseling for people who would not have otherwise come to the site. We go out there, we do what we call mobile HIV testing and counseling, where the site will move the services. You move the services from the site to for instance, a community place, maybe in a highly populated place, in a marketplace, in a school. For instance, we have one of our sub-partner who works with the trackers. So they'll move from the site and go where the trackers are. And so you kind of prompt people to think about it. At the site, people will walk in. Mostly they'll come in, they'll decide and walk in, but you can provide those services that you go out and provide for people out there. We did train counselors for the UNGANA project, and counseling is stipulated by NASCOP. NASCOP accredited some institution. One of them is Lvct Health, who can train counselors, and they are certified by NASCOP. Using the national guidelines and national curriculum, we have been able to train a good number of counselors, and especially for the sub-partners. And for the sub-partners, what we do is that the sub-partners, they are free to recruit their own staff. However, if their staff who have been recruited lack a certain skill, that is then when we come in to build the capacity.
Capacity building within Lvct is an ongoing evidence-based process where we enhance the capacities of local organizations and the individuals who work there to make sure they provide quality service delivery. The capacity building division and work is embedded in the 3rd pillar within Lvct Health. We look at 3 main arms of capacity building, which are the technical, the financial, and the managerial.
We started with the selection of 14 partners whom we've managed to take through financial growth, ensuring that we help them set up policies, build systems, also to ensure that they're able to account and report to the donors. We started first with mentoring the finance teams. where I would take them through the basic accounting, the basic needs in grant management. We started first with calling in all the partners together, where we would do workshops. We helped them through preparing finance policies, HR policies, procurement policies, and also ensuring that the partners would adhere to those policies, not just preparing those.
My work in UNGANA, the grant that's in the UNGANA grant, involves both technical and administrative support for the 3 counties of Ukambani, that's Kitui, Machakos and Makueni, whereby what the grant was supposed to do was, number 1, to strengthen the capacity of healthcare workers in the region, in terms of being able to perform high quality provider-initiated testing and counseling services for clients who are visiting the outpatient departments in hospitals. And then number 2, we're also supporting the government facilities by employing sessional counselors. Right now I can say that the HIV testing rate for people attending outpatient services and also inpatient services in the facilities has improved. And this is actually quite important because it means more people know their status of HIV. The people who did not know their HIV status now know, and they were linked, which is most importantly, they were linked to care and treatment services, and thus this also helps us in HIV prevention, in that the people who know they are negative, we give them messages that will help them stay negative. The people who are positive are given the treatment and they are told on ways on how to curb the spread of HIV.
My name's Martin Oloo. I'm deaf or hard of hearing, and my sign name, that's what they call me in the deaf world. I work here at Lvct Health, initially called Liverpool. My position here, I'm the disability coordinator who coordinates disability programs here at Lvct. It focuses more on serving persons with disability on issues of policy advocacy, service delivery, and capacity building for different disability persons organizations that we work with. We also, in our program, it's a cross-cutting program that brings to the fore other issues in other programs that are here done at Lvct, and that is what we try to do. We try to have cross-cutting issues being addressed in the program and also in the organization here at Lvct. So as far as UNGANA is concerned, this is it had 3 key focus areas that we were doing. One was on service delivery. The other one was we were working close with DPOs, that means disability persons organizations. Since our main aim was to deliver service to them, then we had to do capacity building, sensitize them so that they can be able to serve well. We also had to develop clear strategies for this. And also for service providers, the third one is that we needed to work with service provider for them to offer disability-friendly services. So this comes from basic training on how to deliver service. It also included the partners who are out there, service providers, some of them we work with, and others who are counselors out there, so that they can be able to serve persons who are either hard of hearing, visually impaired, to provide for them services.
From the onset, we started carrying out capacity building in the sense that we were trying to scale up VCT at that time in the country, and so we had to build the capacity of organizations, of other institutions to be able to offer the services. So we've done that for years, and we did that until 2007, when we felt we needed to organize the way we do things, because the requests were coming in, and we really were not able to measure the results. So in 2008, we decided to organize what it would be, and we came up with a program. And this is when Timisha was born. Timisha is a Swahili word that means to fulfill. And we felt we needed to get a word that was representative of what we wanted at the end. We wanted organizations to fulfill their mission, to fulfill their vision, to fulfill what, quote unquote, they were created for. So that's what Timisha stands for. So when we started trying to put together the Timisha model, we looked at many good models out there. There are very many good models out there. We recognize models by MSH, AED, USAID. There were several. But we felt there were things we had learned as an organization that we needed to incorporate into these models. We recognized the importance of integrating gender, or looking at every model and every capacity building process using a gender lens. We also recognized that the way we interact with organizations that are serving most at-risk populations was also different. So we needed to also have that mindset and that lens as we were creating the tools. So that is the uniqueness of the Timisha tool, that we have incorporated these things that we as an organization have learned over the years. So we are contextualizing it and incorporating our experience into the Timisha model. To the partners, I say, you cannot look back. Backwards, never. It can only be forward. You have come from so far, but where you have come from, you can only use that as a platform to where you're going. Where you're going is what is important, and you cannot afford to put down your tools.
Tekeleza wajibu wa kusaidia kuangamiza HIV kwa nia moja. Lvct ikatuleta pamoja, tukaungana, brought us together under the umbrella.